Hello, my name is Ashley Hessen, and I'm here presenting inpatient cardioobstetrics, recognizing and treating complications. I'm presenting on behalf of my collaborators in the cardioobstetrics program, Dr. Elizabeth Langen and Dr. Melinda Davis. So before we get into individual conditions and ways we can optimize our patients' care, I wanted to take a moment and think about why cardiovascular disease is a leading cause of morbidity and mortality among pregnant patients. Of course, there are factors related to the disease itself, the physiology of pregnancy, et cetera. But there was a recent study looking at logistics and kind of healthcare systems-based contributors to morbidity and mortality. And it identified delayed response to clinical warning signs as a major risk factor for most serious conditions, but notably in cardiovascular disease, that was the leading contributor from a systems standpoint as to a cause of a pregnancy-related death. So we'll be focusing a lot of this presentation on warning signs, how we can recognize them, and how we can escalate care. So in recognizing abnormal, it's one of those, when you see it types of things, but certainly a rapid respiratory rate, being short of breath at rest, being short of breath laying down or feeling like one's drowning when laying down, having irregular heartbeat, or certainly an irregular heartbeat in the setting of passing out, or presenting with new acute chest pain. These are all abnormal, and these are abnormal in the setting of somebody with or without a cardiac history. So one of the things we'll be kind of reviewing again and again is that acute events of a cardiovascular nature can occur in people with or without cardiac disease. The way you become someone with cardiac disease is having one of these things happen, and in addition to the various congenital causes, et cetera. So we really do need to be vigilant for these symptoms in our patients because there could be something dramatically wrong. And that probability increases when there are abnormal signs. So we know that there's a physiologic tachycardia of pregnancy. However, a resting heart rate of greater than 110 is not normal. A rapid respiration rate greater than 24 per minute is abnormal. And also a young, healthy pregnant patient should never have an O2 saturation below 96. Occasionally, there are acute causes like atelectasis after surgery or a mechanical issue like a pulse ox that isn't quite on her finger. But in general, women who we're taking care of should always be saturating above 96. So that's a warning sign as well. And then we're familiar with the blood pressure warning signs. So a systolic blood pressure above 160 or a diastolic above 110. Then certainly in your physical exam, crackles on auscultation or irregular heart rate, that's not normal. That's not normal in anybody. So certainly if we recognize that, we need to figure out what to do next. And then risk factors. So we talked about women who don't have any history, but what about those who do? Anyone with structural or functional heart disease is at a higher risk of a cardiovascular event. Then those women over 40 who are taken care of more and more often, women who are obese, women with diabetes, hypertension, and substance use. And all these categories, we frequently have patients who have these issues on our floor. So those should be raising our antennae, really making us more aware that a cardiovascular event could happen. And then kind of just thinking of pregnancy as a stress test, that increase in blood volume, that increase in heart rate, that's testing the system in a way that for many women, it hasn't been tested before. So complications can arise just from the fact that women are in a physiologic state that they often have not experienced. So it may be unmasking something that they could be predisposed to. Thinking about pathology-based risk, though, there are conditions that are high risk and very high risk in a recent taxonomy. And high risk conditions are those with elevated morbidity and mortality. So when you see a patient who has one of these things, these should really kind of drive home the fact that we need to be looking for abnormalities and cardiovascular abnormalities in addition to obstetrical ones. So mechanical valves, we'll talk a little bit about anticoagulation and mechanical valves soon. systemic right ventricle, and specifically Fontan circulation. So Fontan is a surgery that is done most frequently for hypoplastic left heart syndrome, where the right ventricle becomes the one that is supplying the body. And in that situation, because of their prior surgery, but also because of some factors of their underlying process, they're at risk for bleeding, they're at risk for clotting, they're at risk for inability to maintain forward blood flow, and also pulmonary edema. So a lot going on there. And then certainly cyanotic heart disease, or various aortopathies with dilated aortas of different sizes. Then very high risk conditions have significant morbidity and mortality risks. Pulmonary hypertension is the classic scenario, but certainly systemic ventricular dysfunction, so an ejection fraction below 30%, or New York Heart Association class 3 or 4 symptoms. That means you're unable to do basic functions like move around, dress yourself without significant symptoms. So we have more and more patients coming through our clinics who fit in these categories and who are choosing to continue pregnancy. So we may be seeing more of them on our floor. Also, anyone with previous peripartum cardiomyopathy is at risk of decompensation, especially if they've had a residual impairment of their left ventricular function. Then women with severe mitral stenosis or symptomatic aortic stenosis, they're at risk of decompensation, especially around labor. And then Marfan syndrome, or a bicuspid aortic valve, where women have severely dilated aortas, they're at risk for some catastrophic events as well. And then also native severe coarctation. So these are conditions that if you see, or if you're getting handoff on a patient with one of these, then kind of reviewing these slides, reviewing these processes might be helpful. So then pathology-based risk, not all of the congenital heart conditions that we see are created equal. It often becomes an alphabet soup, and I certainly haven't helped that with this slide, but this is intended as a reference. So all of these conditions that are abbreviated are listed down below. But I just want to point out that some conditions, most often those that have been surgically corrected, have a higher risk of arrhythmia, where certain are more predisposed to heart failure. So just thinking about the pathology that your patient's presenting with and what her individual risks are, because for some it may be arrhythmia, for some it may be failure, for some it may be MI or dissection, et cetera. So now we're going to go through 4 key complications. And we've arranged these in a way where we're talking about risk factors, presentation, what we can do, and then OB issues for each. And they're designed to be kind of brief references if you were to want to print them or refer to them in the future. So first, heart failure. Who's most at risk? Well, anyone with cardiomyopathy, so a known weakened or abnormal heart muscle, especially those with a depressed ejection fraction below 30%, are most at risk, as well as those with severe valvular disease. And often, something that we see very often, preeclampsia is also a risk factor for heart failure. So, and being aware that a lot of the symptoms of preeclampsia, the swelling, the dyspnea, that can overlap quite a bit and make heart failure hard to diagnose in those patients. So if you're seeing somebody who is having worsening swelling in the days postpartum and is becoming less functionally capable, that might be something to bring to the attention of other team members so that we can work together to see if she needs additional care. How does it present? Well, desaturation, tachycardia, hypotension, all those abnormalities that we talked about. Also dyspnea, extreme fatigue, and inability to lie flat. Patients will talk about feeling like they're drowning and need to support themselves to kind of keep that fluid in a more favorable position. Then as far as next steps, chest x-ray can identify pulmonary edema, and that's that picture in the middle showing those cloudy opacities. But it can also exclude other pathologies such as the pneumonia. In current circumstances, that's particularly important. And then a BNP, this is a marker of how much fluid is stretching the heart. So It can be an indicator of something going awry, but also just a BNP that's above 100 has prognostic value in predicting an adverse event in pregnancy in and of itself. And of course, an echo is our study to confirm. What can we do in the immediate setting? Well, somebody that you're worried about for this pathology, having them on continuous pulse ox is really helpful. Keeping strict I's and O's is so important in these patients to know what's going in and what's coming out, because we'd actually consider additional interventions such as Lasix based on those numbers, and they're reviewed multiple times a day. Having good IV access, because they become more and more difficult to get access in. And then occasionally, especially for women with known cardiomyopathies, having them on telemetry can be helpful because they are at risk for arrhythmia. So then OB concerns, patients can push in a left lateral position that can take some of the pressure off the major vessels and make it easier for them to get good forward flow from the heart. Occasionally, they may need an assisted delivery, and that's just because their cardiovascular pathology is just overwhelming in the setting of the exertion that's required in the second stage. Rarely do we need to do a cesarean birth in this setting, but just being aware that going to the OR for some reason may be in your patient's future if she has severe decompensated heart failure. And then keeping close track of how much is going in the way of fluids. This is a great way for us to collaborate, because sometimes patients are getting more fluids than we're aware. So one thing we can do is consider IM versus IV oxytocin in these patients, so they're not getting another infusion. And then drugs to avoid would be Methergin because of the potential for ischemia, and IV labetalol, which can cause further decompensation. And I did want to share with you just the outcomes in these women. So HF here is heart failure, and then we're going across the three kind of phases: antepartum, delivery, and postpartum. And as you can see, the heart failure group has a greater incidence of all these terrible events pretty much across the board: mortality, DIC, mechanical ventilation. So just knowing that it's not just their heart, but this is a systemic problem, and they're at risk for pretty much every bad thing, unfortunately. So then moving on to arrhythmia, who's at risk here? Well, channelopathies, so that would be like Brugada, where the heart doesn't manage ion flow and electrical circuits in a normal way, or a reentrant circuit, where the wiring is prone to kind of getting stuck in certain pathways, to put it simply and visually. Also, those with hypertrophic cardiomyopathy or prior heart surgery. So that has to do with abnormal heart muscle just not conducting electricity in the same way that normal heart muscle does. So whenever those circuits go awry, that's where you get the arrhythmias. And how do they present? It could be an irregular heartbeat or a fast or slow heart rate. Also syncope. So cardiac syncope is definitely a major warning sign, and something that we would want to do a further workup for to see, is it a cardiac cause? Is it a neurogenic cause? But an abnormal tracing on a pulse ox can also be an indicator. So having sudden jumps from fast to a slow rate can be indicative of an abnormal rhythm that the computer is just trying to figure out when it generates the tracing. So next steps, though we ultimately may end up with telemetry to identify acute changes, diagnostically an EKG is most helpful because that can give us the most information about the underlying rhythm and kind of help us figure out the appropriate next steps. Checking electrolytes is also important too, though, because in a structurally normal heart, abnormal electrolytes will put people at risk for arrhythmia. Specifically, magnesium, potassium, and phosphorus can cause issues. And then in terms of managing the arrhythmia, that's all based on the ACLS guidelines. So I'll refer you to those, but we'll talk in a second about which ones you might want to pay particular attention to. And then just as a reminder that in terms of fatal arrhythmias, a prolonged QTC interval on EKG can predispose women to concerning arrhythmias, and that interval can be affected by medications. So specifically Zofran and azithromycin are big ones on L&D, but I wanted to share with you this website, crediblemeds.org, so that if you're ever taking care of a patient with a long QTC or a long QTC syndrome, that you have that reference available, since it's so important for us to work together to identify potential risks. We can all take a look at that website and kind of look at orders and say, is this patient on something that she really shouldn't be? Then another OB concern, we always know we can always end up in the OR, even when we really hope not to. So thinking about device management, such as an ICD or a pacemaker, and what we would need to do with that device if we needed to convert to the OR. That might mean turning it off with a magnet. So just having a good team plan for that. And then in terms of arrhythmias, in panel A, we're showing that they are increasing over time in terms of their percentage of hospitalizations. And then looking at, in panel B, at frequency of arrhythmias in pregnancy hospitalizations by arrhythmia. They're also going up over time, but the most prevalent ones are atrial fibrillation and paroxysmal supraventricular tachycardia, as well as paroxysmal ventricular tachycardia. So in thinking about those ACLS guidelines and saying, like, what do I really need the most? Thinking about how you would manage or contribute to the management of those conditions is probably the most high yield. In fact, we've had multiple patients who have needed cardioversion in pregnancy for hemodynamically unstable atrial fibrillation this year alone. And that brings us to aortic dissection. So who's most at risk? Well, anyone with a dilated aortic root, but also those with connective tissue diseases, specifically Marfan's and some forms of Ehlers-Danlos. These individuals can have dissections with or without a dilated aortic root, but are thought to be at higher risk the more dilated the root gets. Dissection unfortunately presents as a catastrophic event with tachycardia, hypotension, and death. Severe chest pain radiating to the shoulders and abdomen, that is kind of the most classic presentation. So if you ever have a patient presenting with that, even one who doesn't have one of these diagnoses, then time is life in terms of identifying dissection, which is what the red arrow is pointing to in the middle, that blood collecting in the aorta. In terms of next steps, depending on the acuity of the situation and how the patient's presenting, it might be a chest x-ray or a CT angiogram, but it could also be transferred to the ICU or surgery. One of the things that we can do on our floor to hopefully mitigate a catastrophic event would be to aggressively treat hypertension, and IV beta blockers like labetalol are first line for that. But also avoid things like Nethergen for hemorrhage, and certainly think about delivery planning in advance if it's not an acute scenario. So let's say you just have somebody who is at risk for dissection with a dilated aorta, then think about, well, what is the safest way for this patient to deliver? The rule of thumb is generally, and these numbers were on a prior slide, but for an aorta greater than 5 centimeters, we start to think about a planned cesarean in those cases. The evidence is not amazing, so there's often kind of a multidisciplinary discussion about how at risk that patient is. But for a lot of patients with smaller dilated aortas, some degree of pushing is thought to be safe, especially with really great pain control with an epidural. If you look at the number of events by underlying condition, though Marfan is the most prevalent contributor to these events, what I wanted to draw your attention to is on the right. So the fact that the second most common diagnosis is no diagnosis at all, so that you can have a dissection with no known underlying issue. And that's why it's so important to pay attention to those abnormal vital signs, and also to listen to women when they're presenting with those concerning symptoms. And then on that note, myocardial infarction. So we take care of a lot of women who are at risk for this rare event. women who are over 30, smokers, those with chronic hypertension, diabetes, anemia requiring transfusion, postpartum infections, and unfortunately, Black women who are of Black race are also very at risk for this, and that's thought to be due to many factors involving bias in the practice of medicine. So really, if I can underline one point, it's that listening to women, hearing their concerns and acting on them is one of the best things we can do as a team to advocate for their care. Because we're finding as we dig more and more into disparities in healthcare that a lot of it has to do with making sure that women are heard and that their symptoms are taken seriously. So then in terms of how, getting back to myocardial infarction, it presents, again, tachycardia, hypotension, and death are late signs, but substernal chest pain is classic, jaw pain, dyspnea, nausea, and syncope. Importantly, women don't tend to present with substernal chest pain as much as men do. They tend to present with the shortness of breath, the nausea, the things that sound a lot like pregnancy. So listening to women, and if they think that something is wrong, taking it seriously can really help identify this potentially life-threatening condition. So the next steps would be an EKG, troponins drawn serially, and then potentially, if there were, as is in this EKG, an ST segment elevated MI or even non-STEMI, the question is conservative management versus percutaneous management, stenting, and bypass surgery, none of which are ideal in a pregnant patient or an immediately postpartum patient for a variety of reasons. But the key point, since obviously that's beyond the scope of this talk, is getting to the point where those decisions can be made with spared time and heart muscle. Because certainly all of that would take some coordinating to accomplish in the setting of pregnancy. So then OB concerns, I already talked about the non-specific presentation. There unfortunately is a high rate of fetal loss in this situation, even with treatment, and there's a subsequent risk of arrhythmia and heart failure. If you look at the different groups who are predisposed to myocardial infarction in the antepartum, peripartum, and postpartum periods, you'll see that hypertension is a major contributing factor, especially in the antepartum group. So I want to draw your attention to that since we take care of so many women with high blood pressure. And then also smoking, 62% of women with an MI in the antepartum group were smokers. And then we'll get into the anatomy of the coronary infarct, but suffice to say that this is a highly morbid situation with a lot of deaths of mother and infant. So early recognition, early care, and hopefully preventing one of those outcomes. Other considerations in special cases, I touched on mechanical valve. The anticoagulation in these cases is complex. It requires pharmacy, OB, and nursing to really be on point and to all communicate with one another to avoid both supra and subtherapeutic anticoagulation dosing. So this is just, I guess, a little PSA to say always speak up if you think something's wrong. Always ask a question if you're unsure kind of how to manage a drip, for example, because we all need to help each other avoid issues like a valve clotting off, which unfortunately is common in women who are anticoagulated with mechanical valve. So then postpartum hemorrhage risk, I've given you many cases where certain uterotonics are not ideal. So that in itself is a risk that we can't treat atony in the same way that we would other women. But then also certain conditions come with a hemorrhage risk, like Fontan, for example. Women who've had this procedure have a paradoxical tendency to both bleed and clot. So they're at high risk for postpartum bleeding. And then remembering that there are certain high risk windows around epidural placement immediately postpartum during pushing, where women's cardiovascular systems are under their most stress. So that's when we need to be the most vigilant. And then also working together to quickly transition care through the system if needed. I love working here and I love this hospital system, but I do wish that the cardiac ICU was closer to L&D. So making those transfers happen early if needed, and as seamlessly as possible is something that we can do together to optimize care. So, with that being said, I thank you for your time. I encourage you to reach out to either myself or Dr. Langen if you have any questions or concerns. And I just want to say thank you so much for all the amazing work that you do. I feel very privileged to be a part of your team.